Lisa Finlay and Andrew Eccleston would be having words with me. So I thought rather than try and run through a huge amount of stuff, I would give you my own personal approach of the way I approach respiratory problems in children. I'll give you a couple of case examples, and then if you've got cases you want to ask me about at the end, then feel free. Is that okay? So, the first question I ask myself whenever I see a child with a respiratory problem is it an upper airway problem or is it a lower one? And I think if you can work that out, it makes it really, really helpful in terms of treatment. And the way that I do that is, I think if it's a respiratory problem at all, usually you have an increased respiratory rate. And if it's a child, and I'm worried about them, or I want to really work it out, then what I actually do is I will sit there for a minute and actually count the respiratory rate. Because there are lots of shortcuts in medicine, but if you want to truly work out the respiratory rate of a child, I'm afraid you have to be a bit boring and actually time it for a minute. I really don't think there's any shortcuts around that, and particularly younger children. If you want to know the respiratory rate, you have to time it for a minute, really, because they do a lot of periodic breathing. And the normal respiratory rates and all the normal rates are available through the Hippo. It's not called Hippo now, it's Beacon, isn't it? Through that website. If you look up the acute paediatric guidelines on there, they give you normal values for, from the APLS for all of these things, for respiratory rates and heart rates. Work of breathing. Now that sort of is important to see how much recession they've got, how much nasal flaring, does their chest meet their spine when they take a breath in. It's quite useful to appreciate how hard they're working. And then auscultation. And that tells you how effective the breathing is. Because they might be working really hard, but they still might be managing to shift some air. If they're working really hard and they're not shifting any air, you've got a real problem. Saturation. Some of you will have pulse oximeters and some of you won't. And then temperature. I don't know whether you have ear reading thermometers in general practice. Very useful devices and very helpful, I think, when you're assessing children, because you're then thinking about whether it's an infective cause, whether it's a virus that's making them wheezy, or whether it's some sort of chest infection. But the temperatures can be very useful. So I then had a quick think about what the upper lesions would be. So nasal blockage in young infants, stridor. As you can see, a really sick child, and sometimes you think about bacterial tracheitis, which is pretty rare, or epiglottitis, which we hardly ever see now since the vaccinations. But you can still get them. And then I think about lower stuff, and there's probably more stuff that's lower than these are just ones I put off the top of my head. So asthma and viral-induced wheeze, bronchiolitis infection, cystic fibrosis, foreign body effusions, and rare stuff that you probably would see once in your lifetime. So I've seen a T-cell lymphoma that presented with stridor, and actually we had to give them steroids before they could even have an anaesthetic to then get it biopsied, because it was just very difficult. And there's rare congenital stuff and things. So,
hello, can you put the slides up for us to see, please? We can see the slides.
Yes, we'll get Callum to come and do that for you. Fortunately, I haven't got very many slides, so basically, these are some rough rules of thumb that I have, and that's it looks like the folks are used to it. Can you see the presentation now? Can you see the slides?
Yes, we can. Thank you.
Okay, great. So, so we did a study must be about 6 or 7 years ago in schools now, where we actually asked parents how long it takes for children to have colds and how long it takes them. And actually it's 14 days. 10 to 14 days is how long the symptoms start to when they end, if you ask parents at home. If it's longer than that, then that's a little bit unusual, and you might think, well, what else is going on? Could it be asthma or some atopy, or I suppose it could even be sort of rhinitis. If there's no response and you think, I'm not really sure this is asthma, could it be something else? Then something to think about. In an adult, 4 weeks, you'd get a chest X-ray, wouldn't you? Well, that's what I was taught when I was a medical. It might be 3 weeks now, I don't know. But sometimes it is worth getting an X-ray in a child, which I think is probably underdone, and considering antibiotics for wet coughs. So I'll give you 2 case scenarios, and you can tell me what you think. What do you think is going on with this child then? These are all based on real cases. I see 4 or 5 of these every winter. Silence.
Fever?
Yeah, well, say temperature is 37.5, just for the sake of argument. Yeah, so actually probably a lot of them have RSV, but it doesn't actually affect their chests. It just causes nasal obstruction. And because young infants are obligate nasal breathers, it can get really marked recession. And actually by sometimes using just normal saline drops. So they come into our ward, we'll give them some normal saline drops, some suction, and then sometimes they'll just manage with normal saline drops. And if they manage with just normal saline drops, they can just go home. And it's really the upper airways that's the problem. It's not actually the lower airways that's the issue. So normal saline drops are very good for young infants if they've got nasal congestion.
You would use that rather than a decongestant drop?
Yeah, I think just normal saline drops seems to work quite well, and you can say to them, pre-feed is often a good idea, so that it loosens them up so they can suck feeds. And I'd often say, reduce the amount of feeds and give it more often, so maybe half the amount of feeds, maybe feed it every 2 or 3 hours, and that often works quite well with these babies. Yeah. Any other thoughts or questions from you, Stuart or Stranraer?
No, thanks. No, sorry.
Okay. So, any other questions or thoughts about the case here? Okay. So, this is the child I saw in Stranraer on Tuesday, actually. So, one history of a cough, it was quite a moist sort of wet cough, no response to inhalers, no response to amoxicillin. What do you think we should do, or what do you think is going on here?
X-ray.
Yeah, so I did an X-ray, and what do you think it showed? I asked the GP to arrange it, and the GP very kindly said, thank you, Stranraer, for organising the X-ray. And what do you think it showed?
Nothing.
No, it showed bilateral consolidation. So yeah. So I think the things that would push me towards an X-ray is, you've got this history of a year, and it's a wet cough. It's not responding to inhalers. It's not responding to some oxygen. So that was the sort of report. So what do you think I did then? No. Yeah. Which antibiotic do you think I went for? So yeah, I went for coamoxiclav, and I think Lisa Finlay and I often use this for our chronic infected lungs that haven't responded to first line agents. Now, which preparation do you think? And there is a reason why I'm asking this. Yeah, and that's prescribable as 400 to 57 rather than the other strength. And the reason why I might do that? Yeah, augmentin duo, yeah.
Is it just compliance?
Yeah, it's compliance really. It's often, if you try and give medicines to children 3 times a day, it's really quite difficult. So twice daily is often more manageable. So I often go for Augmentin Duo. And we'd use a much longer course in this situation. So when I saw him in clinic on Tuesday, he'd had about 10 days and the cough had gone from 10 out of 10 to 4 out of 10. So I said, well, take another 3 weeks. And we'll actually use up to sort of 2 weeks and see what response. But if it's not getting better at 2 weeks, we'd often give them 1 to 3 months of Augmentin Duo to treat a chest X-ray probe and consolidation with a history of a year's. Because if that's been going on for a year, it's not going to get better with just 2 weeks of antibiotics. So hopefully at the end of 3 or 4 weeks of antibiotics, that'll be better. And sometimes that's enough. If I said to Mum, if it comes back, then we would investigate and we'd do further tests. But it's just maybe an untreated chest infection. So, any questions or thoughts about that in my remaining 2 minutes?
Did you manage to get back to your old? How would you do it?
Well, if you wanted to, the way to do it is to get an induced sputum. It's really awful for the children, and sometimes they tend to swallow it. So I tend not to do it. You would give them a hypertonic hypertonic saline neb, and you would then get them to cough and retch, and then you'd repeat the neb, and then the second time you take the samples, you do second and third times. So I tend not to do it unless I really need to know. Yeah. Any other questions or thoughts?
Jen's work the night again. That Jen goes everywhere.
Do you think the consolidation was there for a year?
I think probably there's been an infection that's been going on for a year. Now sometimes at the start you see it as perihilar thickening. Sometimes you see it as sort of consolidation on the X-ray in the bad cases. But yeah, I mean, I can't really think of any other explanation as to why this child would have had a wet cough for a year that's not responding to treatment. So yeah, I think there's probably been some grumbling inflammation and infection in that child's lung for a year. Yeah. Any other questions or? Okay, well, any other cases that you want, or questions that you want to ask about any cases that you've had? If not, I will sign off.
I was going to ask, the standard course of antibiotic, 100 ml bottle of antibiotic is a 5-day course.
Yeah.
Do you think that's adequate? Assuming we should be using an antibiotic in the first place.
I did general practice before I did paediatrics, so I understand that it's not quite the same as being in hospital. And I think if you're giving an antibiotic because you think that's just in case, then I think 5 days is probably reasonable. I think if you have genuine signs, like you listen to the chest and there's genuine crackles and the child's got a high temperature, you think, I really think this is a chest infection, then I think you should give 7. So, if it's a just in case, then 5 is probably okay. But if you think, no, actually, I really think this is a chest infection, I would give 7. And in the cerebral palsy kids, and the ones with the spinal deformities, I would always give 14 days because they don't usually respond after 7.
Can I just have something on there?
Yeah, sure.
You might come across, and I think it's a common sort of scenario we do come across, where a child has a wet cough, and then the GP gives a week of antibiotics or 5 days of antibiotics, it gets better, and then it comes back again a few days afterwards, or a few weeks afterwards, and hence report that we just can't get rid of this, but let's check around and get back into antibiotics. So I think that's particularly the sort of scenario where we would commonly give this prolonged course of antibiotics, because you've got an infection, and the infection is probably cleared up with the antibiotics, but there's sort of an inflammation there, so that can last every number of weeks after the infection, and so you're vulnerable to getting further infection. And so the purpose really is not just to get rid of an infection, but to prevent any further infection over the time that you've still got inflammation there. And so that's why the reason as well.
Yeah, yeah.
That's interesting. Personally, I think I'd be quite averse to giving a month's course of antibiotics.
We don't.
I mean, you know, this isn't something we do commonly, but it's something that we do. Right. And I think if you've got long-term respiratory symptoms, you know, plus you've got some evidence on a chest X-ray, then I think, you know, you need to give a much longer course, I think.
Next step after this would be going past the CT. So you know, well, slightly testing over in neurological investigations, but you know, quite a big step up in terms of investigation. So,
did you consider steroids?
No, I didn't. No.
But you might, if you were doubt, might you about
yes,
you were
yes.
for the more atopic sort of, and you thought, well, I'm not sure whether giving this regularly or what's happening, and it can sometimes be useful to try a sort of good old course of steroids. Yeah. Well, we do that slightly less often, but we do it.
Yeah, so if we think the child's atopic and we think they can't take inhalers, we'd often give a 5 or a 7-day course of prednisolone, 2 milligrams per kilogram with a maximum of 40. Yeah, it's not steroid responsive if it's not, and it's unlikely to pass. Anyway, I better finish it. Thank you so much for inviting me, and wish you all the best with my eminent next speaker.
Okay, everybody. Hello, I'm Andy Finlay, one of the paediatricians. I think I know a lot of people, but just anybody that doesn't know me. I'm just going to go through, I'll show you the format that I was going to use. So I'm just going to talk about a couple of cases, just very briefly, and then briefly about the, you know, what I imagine might be the challenges for you, and see if I can help in any way with that, and then just have a discussion of any cases or any issues that you might have in relation to child protection. So when I'm thinking about the cases, I do have a few slides which are a little bit dense with small writing of evidence, which we don't need to go into in any great depth, but I'll just make you aware of where you can find them. Okay. There's no point in really reading every word of it, I don't think. So this is a case that occurred just towards the end of last year. In the handover in the morning, I was the ward consultant. I was told that there was this little baby, not this one, but it could have been, a little 6-month baby with a bruise to her forehead. She was absolutely well, and parents said that perhaps she'd fallen over from a sitting position. So she's 6 months old, at the sort of stage where she would just about be able to sit, but she probably would be a bit unstable, so absolutely she could possibly have fallen over from a sitting position. So so you're reading through the notes, I don't need to read every word here. This is the story. Put on a carpeted floor, and she was said to have mum heard a cry, came back in, didn't notice anything particularly, bathed her, and then she vomited. So mum was concerned that, you know, she'd maybe hurt herself as she'd fallen, and brought her up to A&E where she was seen, and she was noticed there to have a little bruise on the right side of her forehead and another little mark on the left side, a little small red mark, not even one you would call a bruise. Mum couldn't really explain how it happened, but she suggested that the baby had perhaps fallen forward and hit her head on the wall and then fallen backwards, so sort of double impact from an unstable sitting position while she'd been running after another sibling, I think. So there was the bruise, 1.5 centimetres, a little red mark on the other side, no other marks. Clean little happy baby interacting well with her parents. So that was what it looked like. What should we do? How hawkish do you feel? Difficult, isn't it?
Nothing previous to that.
Nothing else. Nothing that we know about. This is all we've got so far. Yeah. Okay, so should we look further, do you think? Any further at all?
Both sides of the head.
Yeah, it is a bit.
It sounds like they're different ages as well. One's a bruise and one's a red mark.
One's a red mark, one's a bruise. So, you know, the baby looks really well. There's nothing ringing any alarm bells from what you see in front of you. But obviously we're not seeing the whole picture here. We're only seeing one little bit, and that little bit looks not completely reassuring, because this is a non-mobile baby who has a bruise, so in fact 2 marks. So what does the evidence say about this? Well, you know what used to be called Welsh core information, child protection evidence? I don't know if you're familiar with that or not. You maybe don't have much cause to look it up. It's basically a sort of database of collection of good-ish, as good as we've got, evidence about child protection and how to interpret various findings in child protection. It's no longer funded, so it's now stored and being developed by the Royal College of Paediatrics. So if you want to find any evidence, you can go onto the RCPCH website. You don't need to be a member of the RCPCH to do it, and you can find out all the evidence that is available, the best evidence that we've got. And it's an ongoing system that's been constantly updated. So it's the best that we've got. And child protection evidence is always a bit difficult because it's always hard to divide the children into groups that have definitely been abused and children that definitely haven't. And so therefore the evidence is often somewhat limited, but it's best we've got. So it says the number of things that might be indicative of abuse, and the one that we can see here is bruising in children that are not independently mobile, which includes children with disabilities that are not independently mobile. But primarily that group is babies, isn't it? Bruises that are seen away from bony prominences, bruises to the face, these areas that we're familiar with are just a bit unusual to be bruised accidentally. And of course multiple bruises that look like something, particularly an implement of some sort. Bruises on the ear, fingerprint type bruises, very easy. But what do you know, we've only got this here now, we've got a bruise in this non-mobile baby. So these are just marks, and not on this baby, but so there's a cluster of bruises down in the first picture. Here it's a really easy one to interpret, isn't it? A big palm print over a fingerprint over somebody's face. You get this level of bruising as well without a good accidental, significant trauma, then obviously that's highly suspicious too, isn't it? Oops, we'll go back. So multiple bruises, uniform shape, could be fingerprint bruises. Implements, bruises that are associated with petechiae, that's actually really very strongly associated with child abuse. If you've got petechiae around a bruise, there's a really strong positive predictive value that the child has been abused. So you can't age a bruise by examining it with the naked eye. Now that sort of goes against what we all feel. I think you're mentioning different ages of bruises, and I think instinctively we would feel, sure, you can, but the evidence is that it's not reliable to be going by colours and things like that. So we can't really, back that up with evidence if we do it. So this is the stuff that I said was a bit dense, and I don't think I want to read it all out to you, but it just sections from the evidence here. It talks about all the evidence that there is and what might be useful to pull out from it about how risky it is that this baby has been bruised. So if we look here in the first study, we're talking about bruising patterns, and where the bruises to the ear, face, neck, torso and buttocks are significantly more common in abused children than an accidental injury. So this child has got a bruise to the head. And then we're looking at children under 3 in this study, and we're looking at their oral injuries, ears, neck, jaw, and we found that quite a lot of those children have been abused, and some of them have had bruising. These are the areas again that we're looking for. Some of them are petechiae. So oral, jaw, neck injuries, that's obviously highly suspicious as well. So you have to bear in mind where the bruising is. So the head is the commonest site of bruising in child abuse, but obviously it's common in accidental injury too. Very interestingly, one study looked at 3 children less than 5 months, each presented with bruising to the face which wasn't investigated further, and all 3 represented with abusive head trauma. So that could be a sentinel injury. So the point there is that that's a trivial injury in itself. You're not worried that the child's going to have major intracranial trauma. On the other hand, it was a clue that there was something very serious going on there, which these children went on to do very badly and be seriously harmed. So in this case that we were speaking about that actually happened in Dumfries towards the end of last year, we had the IRD, and that's the discussion, it's an initial referral discussion between social work, police and health. So we look at all the information that we've got on our records to see if there's anything else concerning coming out. And absolutely nothing, no concerns at all came out in that. Everybody said that they had absolutely no worries about the family. There was an older sibling as well, no worries about the older sibling either. However, we decided to carry out the investigations anyway, simply on the basis that this seemed to me to be somewhat unexplained. The 2 marks, on a non-mobile infant. And I didn't like doing it because it felt a bit over the top, but all the same, I felt that the evidence probably supported it. Also checked clotting, just in the off chance that there would be something wrong with baby's clotting that might have caused the easy bruising. So the Scletal survey report was that there was everything else was normal apart from an unexpected healing fracture of the left fibula. So there was a healing fracture that there was no explanation for in the baby that was investigated for a bruise that didn't quite make sense either. So it's starting to look a little bit more concerning, isn't it? So we've got this, as I say, no concerns about the family. How worried should we be? Pretty worried, I think. Yeah, pretty worried now. Yeah. Okay. So the evidence then is they're looking at 3 studies, children under 1. Again, there's difficulty of categorising them into abuse and non-abuse, but for now, the purpose of this will assume that that was a reasonable categorisation. 25 to 56% of all fractures in children under 1 were due to abuse. So this is, showing the level of significance to a fracture in a child that's not mobile. It's pretty high, really. And the highest incidence in abusive fractures was in the very young ones. So, if you get a fracture in a very young child, it is highly suspicious. Looking at the tibia and fibula fractures in particular, it's a relatively small study, 24 children, 23 of the ones that had tibial or fibular fractures were felt to be abusive if they were under 18 months of age. So now we've got a 6-month baby who's got an unexplained bruise and a red mark, who's got unexplained fracture, and of the type of fracture which is found in the vast majority of the cases that you get this type of fracture, it's abusive, according to the evidence. So the odds ratio for abuse is 12.8. So that maybe is nearly 13 times more likely to have been abused than not, according to the evidence, which is limited, but that's the best evidence we've got. So it's quite interesting, isn't it? It would have been quite easy to ignore that. So what happened? The child and the sibling were put in the child protection register. The family were obviously devastated, but engaged well with services. Did we do good? Or didn't we? Caused a lot of distress.
Was there any sort of backstory to it? Was there ever any explanation?
Never any explanation. That's it. We don't know now. It's in the hands of social work. I went to the cases conference in the first place to try and make sure that they were definitely put in the child protection register because I thought that the evidence supported that. But, and I think it did. But I think there's very much a question of, has good been done there or not? And I'm glad I didn't miss it, but on the other hand, there's a lot of distress caused. There's no answer. It can be difficult. So some cases are more obvious, but not necessarily easier to deal with because they can be quite traumatic. I think probably the paediatricians know about this, but we had this one very recently. Infant with a bruised forehead. She's 8 months. She'd been seen by her GP in relation to a virus. She'd just been on the ward recently, actually, with it before the discharge home and then this representation. She was noticed by the GP to have a bruise on her forehead and over her eye. She was sent to A&E by the GP, who I think obviously picked up on this quite. Was it yourself or somebody sent the baby in very appropriately. In A&E, baby was undressed and they noticed that she had a swollen right arm, left fingers were swollen as well. She was really distressed, really miserable, multiple bruises, really loads of bruises all over her. Bruises over her face, over her scalp, over both sides of her abdomen, abrasions over one side of her abdomen, a bruise on her heel, a bruise on her ankle, a bruise on her arm, really distressed, sore, miserable child. So she got the x-ray of the arm, and this was just straight off x-ray, no Scletal survey at this point. I'll let you read it, but the basic gist of it is not only was there a fracture of the humerus there, but there were multiple healing fractures in all the bones that they could see there. Highly suspicious of child abuse, to the point that it can only be child abuse. They don't look as dramatic when you look at them on the X-ray, so I'm certainly no expert, but these are the little bits here, and that's the metaphyseal fracture, the bucket handle corner fracture.
Is it the mum that took the child to
the mum took the child, yeah, she did, yeah.
And was it the father that was doing it?
I don't know. So
I can't get inside her head there that she would let that abuse happen, and yet she'll take the child to the doctor with a cold.
Yeah, and I'll carry on and I'll tell you the rest of it, and we can still see if you feel that there's any more sense to it. Personally, I think there's probably even less sense to it, but I'll tell the rest of it. So she got the post-police survey, and again, I won't read it all out to you, but I think that this was the report done in Dumfries. They identified even further fractures than the one that was when we reported it in Glasgow. So she's got fractures basically of both her legs in all the bones. Her fingers, it doesn't even mention that there, but I mean, I'm pretty certain she had a finger fracture as well. She had the really, really nasty fracture of her right arm, right humerus, which couldn't even be easily fixed even in theatre. Just multiple healing fractures in this child, really, really horrific, to be honest. So that's easy. It's clearly clear what you have to do, isn't it? But it's actually really horrible dealing with this type of case, and I think the people that have been working, the nursing staff that have been dealing with this baby in Finlay are really quite upset and tearful about it. I think we just have to acknowledge that and remember that we don't, any of us individually, see these sort of things all that often, and although you may not know what to do professionally, it's horrible, and I think everybody should feel free to acknowledge that and to speak to other people about it and to acknowledge that. I won't by any means try to tell you how to do your job, but I can imagine that your problems are similar to ours some of the time. You're just under constant time pressure, and a child presents with something. You can't completely undress every child every time, I would imagine. We certainly wouldn't be doing that every single time a child comes to clinic. We wouldn't try to undress them completely, it's just not realistic. But we know there are cases like baby P, who wasn't examined by the GP and died shortly afterwards. There has to be a happy medium. If you have any other concerns about the family, then obviously you will have to do a bit more, won't you? But you might not know the family. You see a bruise in a perfectly happy, nice-looking little baby, but it's 5 months old and it shouldn't have a bruise. Do you just let them walk out of there, be carried out by the mum, or do you say, okay, I'm just going to spend the rest of this day dealing with this situation, phoning people, distressing people, that's what you're taking on when you do it. And it is hard to make yourself do that. But if you don't, then you're missing. So the common themes in serious case reviews, the rule of optimism, it'll be fine. Don't you think it'll be fine? Yes, I think it'll be fine, yes. And we reinforce each other's ideas, because that's just the way human beings operate. There can be disguised compliance, which makes it all the easier to believe that things are probably going okay. Very, very easy to lose focus on the child, and I imagine that would be particularly easy for you, because clearly we're paediatricians, we deal with the child, but you're dealing perhaps with other family members as well, and to focus constantly on the child must be more challenging to do that. But that's a common theme, what emerges in serious case reviews, that the emphasis shifted somehow to the parents and the difficulty parents were having parenting, as opposed to, but hang on, the child's in the middle of this and it's not being fed, or this kind of thing. Drift, things are just about, things are not great, but they've always been not great. At what point do you say, well, no, it's just unacceptably not great, it's not getting better. This is where we're actually going to say, no, we're not tolerating this anymore. So that's difficult. It's so much easier just to say, well, it's never been great for that family, and they've never been good. So you can also underestimate risk. That's a very common theme as well. It's common across all the agencies. Social work, I think, very vulnerable to underestimating risk. And of course, we all know that we don't share information as well as we might sometimes. I was just thinking about this in terms of statistics, and if you think that there's maybe I know it doesn't translate exactly because it's not a complete random chance thing, but if you had, you're 75% sure from the little picture that you've seen that things are innocent, you think, well, that's quite a good odds, it's probably okay. But if somebody else is looking at it and they're 75% sure from their picture that everything's okay, and they're looking at a different piece of evidence, and somebody else is looking at theirs and they're 75% sure that everything's okay, when you put it all together and you suddenly start to have a bit more concerns about it and you think, well, actually there are quite a lot of things adding up here that maybe you do need to look more at this. This is how you actually identify problems. So, the jigsaw. So, we borrow somebody else's wisdom, okay? Oops. Sorry. So we have to learn from our mistakes, but hopefully we can also learn from other people's. We can't just continue to do what everybody else is doing because it's not good enough. And that's the unfortunate reality of it. Children are abused, and we can't prevent it, but we can at least try and make sure we don't make the same mistakes again. And that is it's so much easier said than done. And we can't be afraid of getting it wrong. It's a horrible area of child protection because everybody feels that the stakes are so high. But I think we do need to do our best and get in there, look at the evidence and try and make the best decision that we can, knowing that we'll be dealing with uncertainty. So we mustn't ignore bruises in non-mobile children, bruises in unusual places. Some conjunctival hemorrhages are not related to birth injury, so after the first 2 or 3 weeks, they should be gone. If they were there at birth, they should be documented. And if you find them any other time after that, in the absence of some really obvious, horrendous pertussis or really, really severe vomiting, you're not going to sneeze once and develop subconjunctival hemorrhages at 6 weeks of age. So that could be the only sign that there's abuse going on. Bleeding from the nose or mouth of an infant, or parents blaming the dummy, or I think you fell against the dummy, that should be a big red flag because that just really doesn't happen. And obviously the things that raise your concerns about the parents and the family situation. Neglect is difficult, emotional abuse is difficult because those are so nebulous, but we can try and categorise them. So the usual things I think everybody knows: be concerned if a sibling is blamed. Of course, siblings can cause, in fact, they were just saying when we're fighting tonight. Age 14 and 16. So siblings can certainly be responsible, but it should make you a little bit suspicious. A lot of injuries. Teething mechanism not being in line with the developmental stage. But those are not the only things. If you have any other worries as well, you can obviously act on them. You shouldn't be frightened to find out more and refer the child. You're not saying it's child abuse, you're just going to look a bit further and find out whether there is any additional evidence for concern. We don't know how many children are abused, but NSPCC figures suggest that when they go back and they ask children at a later age about abuse, 1 in 14 says that they have suffered severe or significant physical abuse. It's quite a lot. So that would suggest that, our prevalence is probably an awful lot higher than we would be aware of. There's a lot going on below the surface. So children are being abused in DNG and all across the United Kingdom, and children continue to die, and we hear about it in the press, and we blame the press blame people that are working in the areas that are dealing with very difficult things. They're working under a lot of time pressure. It's really difficult. But having said that, in many cases, there will be some clue that we can identify, and there are moments that are important that we might come across without any big warning. You'll just come in the middle of your busy clinic, and that could be the only chance that you might get to change the path. So I think if you're prepared for that and you're aware of it, then you're more likely to make the decision to investigate it rather than just to turn a blind eye to it. That's probably okay. It might not be, probably will be, but it might not be. So if you wait till you're absolutely sure, it might be too late. So that was all I was going to say. I've probably taken too long, have I? So I'm happy to, if I've got time, just to deal with any questions anybody has.
Can you draw any conclusions from child seems happy? Because as a GP, I sometimes see a child that really bonds with you, and as a desperation because they're so anxious.
That's absolutely true. I mean, I think that you probably have your antennae twitching if it's just something that's outside the norm, So if you think, oh my goodness, very friendly, no stranger fear, then that can be a sign of an attachment disorder, which might be a sign of neglect. If they're not frightened at all, just separate from the parents. That could be something. something. We had a little child in the ward a couple of years ago who had really, really obvious sort of frozen stare, frozen watchfulness, absolutely terrified. You come into the room, her eyes just literally followed you around the room. And she just sat there completely undemanding, not looking for adult attention at all. And that's clearly abnormal, and it's important to note these things. It is enough, actually. And it's enough to raise a concern anyway, and if social work then look into it and look at everybody's records and find that there's nothing else of concern, well, that's okay. Better to have looked. And if the child's happy, I think you can't conclude anything from it, but it's part of the evidence, isn't it? I mean, that certainly if there's something abnormal, but if the child's happy, well, the first case that I spoke about there, the child perfectly happy, and the children seem to be emotionally thriving, which is why everybody struggles so much to believe that there was that occult fracture there, but it was, and something caused that. So I don't know, and it's often unsatisfactory because we don't know what, to go back to that, the second case, and who did that, I don't know, but none of the family members could be exonerated. My feeling is, speaking about the more subtle things that, are not written down as part of the evidence, but the mother, whenever I came across her, Andy, very upset about her own circumstances and didn't make any attempt to comfort the child. I don't know who inflicted these injuries on the child, but obviously nobody protected the child. They must have known, that something's going on. So I don't think the child can be allowed in their home environment. It's not for me to make that decision. I can only comment about the likelihood of abuse, so somebody else has to decide.
Have you got a sense of how many cases are looked into that aren't put onto the Child Protection Register? Or, the ones that are thought to be sort of all clear? Because I sense there must be a tremendous pressure to go down the route once you start down the route.
Well, not really, because the thing is, actually, the social work do not want to put them on the Child Protection Register if they can avoid it, because, I suppose they have limited resources for a start, so they have to focus on the children they think really do need it. And they will be statutory requirements of the Child Protection Register in terms of follow-up meetings, and it's quite there's quite a lot of input that you have to put in if they're on the register. They don't want to put them on casually. I mean, it took quite a lot of persuasion. Second child, no doubt, but the first child, they quite happy to put the child on. Because the family seems so nice, and so there's nothing in the family. But as I say, those factors. So lots of children get an IRD, so that's the discussion, with the social work, police, and health records looked at, and then there's just a conversation about it. And at that, they'll decide whether or not they're going to proceed down child protection lines. That would mean that the police would carry out a joint investigative interview of the parents with social work, and we would probably have a forensic medical examination and make it all formal. And then after that, conclusions would be drawn about the likelihood of abuse. And after that, there would be an initial child protection case conference. And at that meeting, we decide whether we're going to put the child on the register. So there are only about 80 children in the police of Galway that are on the child protection register. 80. I mean, it fluctuates. It goes from 60s up to high 90s. But that's the sort of rough scale that we have. The purpose isn't to put them on the register and keep them on the register. The way social work see it, they want them on the register, they want to do something to make the situation better, and then they want them off the register. So the optimal time, as far as they're concerned, is in the region of 6 to 9 months, 6 months to a year maybe, because that's long enough to make a difference, but not so long that you fail to sort of intervene. Whereas sometimes we have them on, like children like that, the first case. Social work can't wait to take her off the register because they feel that they're happy with the family.
Perhaps effort is made to reduce damage to families who've been subject to investigations which have been groundless. I imagine that to be a highly traumatic.
Yeah, I think it. And to be honest, not much. You're sort of spat out at the end of it and just like pick up pieces on your own. Yeah. Mm-hmm.
Is there any evidence to explore how much actual damage is done to the units in this process?
I don't know. I've never looked.
It's not something I'm aware of reading about, but it must be colossal.
Yeah, I mean, I think that's absolutely true. That is the other side of it, you know. And you certainly, when you arrange these investigations, and I know you would agree with me, Andrew, that it's horrible.
Yeah, I mean, it makes a difference how you frame it at the beginning. So, I mean, I'll usually kick off with something like, look, I don't know you, I've never met you before, I know nothing about your family, your house, your friends. Some children who went like this, there's something that I need to worry about. Therefore, we need to look into it. Not my job to make an accusation. I'm not saying that you have a future child. I'm saying that you have a collection of circumstances that require me to follow this action, which gives you a little bit of neutrality. It certainly makes the ethical aspect of the job a little bit easier. Because actually, often, I mean, you know, there are cases like the last one where this child has been abused. There is no doubt about that. But a lot of them, we don't know, and we might never know. But we know that there's enough that we need to explore that further, because we're only looking at a couple of bits of that jigsaw puzzle, and actually we need the whole thing before we really work it out. And you can sometimes get parents to buy into that, not always. The ones who, the judgmental statement, the ones who really don't buy into it are often the ones who are a bit more worried about it, the ones who are. But I have no evidence of that. It's just personal.
But it's horrible for everybody. I mean, I totally agree with that approach, but they still cry.
Oh, it's horrid.
And they just go through hell until, and they never want to see you again. You know, understandably. But, you know,
you can emphasize to some extent. I will often say to people, I know that this is horrible. I'm genuinely sorry to put you through this. I know that what I'm doing is deeply unpleasant for you, and I recognise that. And I'm sorry, but I'm still going to do it. And that is, I find that approach helpful. I get punched.
But I mean, if you don't, you're absolutely sure you're going to miss something eventually. So you're playing Russian roulette. Now, I know it's always a balance of risk, but I think you have to be. Personally, I feel in my practice, I try to be strict with myself about following the evidence, regardless of the fact that it's not pleasant and it's not something you really want to insert into your day or anybody else's day. But you know, if we don't, then I think we'll just repeat these mistakes, and sooner or later it'll happen in our area. It happens in other areas. You know, I think it might happen anyway. But you know, we can at least do our best. Anybody else?
How often is neglect the main cause or the initial cause of concern?
Not often in the sense that we as paediatricians would see it, but Andrew, do you get involved with that quite a bit?
I used to get involved with a lot when I did more work with after children. I still pick up a little bit. So we will sometimes be asked for medical evaluations of children where there is perceived to be some neglect. And I still get involved with some of those to look after service. They're medically more complex because it's not very often you can get a medical thing that sort of nails it. But we can still be part of a sort of multidisciplinary approach to thinking about it.
And is there significant neglect in the ones that you do find that present with, I'd imagine?
Not always. I mean,
I'm thinking my husband's a dentist, and a number of times we have conversations about the issue with dentition in children and how far is that neglect. But you can see that of vast numbers of children with.
Yeah, I mean, you know, injuring a child is relatively binary. You will do something to injure a child that you don't. You shouldn't be doing so. You can, you know, I'm sure that we all occasionally do something that is marginally neglectful for our children. But you know, there's a big, huge spectrum. At which point is the dividing line between? You know, I was looking at my daughter from traveling because it worked. But you know, so we all do things that are slightly substandard as parents, but at some point it becomes an issue, and there is a degree of sufficiency that, you know, that is difficult.
I think in that sort of situation, if you feel a little bit of anxiety that the child that you occasionally see might be being neglected, it probably is worth speaking to the health visitor about it, because health visitors are in person, and they might be able to keep a more of a chronology. That's the idea, that they'll keep a chronology, and that can help to build up a big picture, because if you don't record your minor concern, then the chronology will remain empty. Whereas if everybody contributes their minor concern, then eventually the chronology starts to fill up and you get a better picture, which might actually be of some use then, might actually be able to do something about it. You're not saying you remove that child, you probably won't get that far, but you know, there obviously are some really horrendous neglect cases. And I think we probably all see children that we really have a slight anxiety about whether being found to coming to clinic or to surgery.
What about school-age children? The main person who come back to
well, I mean, school-age children, the main person is a member of the educational staff. So at the moment, it's a bit up in the air. It's totally up in the air as to what we're supposed to be doing about information sharing in regards to the main person if it's a school-age child. So at the moment, I don't think you can do that without the parents' consent. You can't share that information because the most recent ruling about it has put the brakes on the government's plan that we will share information with the main person even through open education because of confidentiality issues. So we will watch this space. Yes, I think if you're worried enough, you'd have to speak to social work about it. You could just have a chat with them about it. You could also talk to the child protection advisors. If you're not sure what to do, you can speak to them. They might tell you to put a referral to social work, but at least you'll know you're doing the right thing. Anybody else? So Nora, anything to share? You got? Okay. Lovely. Thank you.
Just try and get mine fired up. So I think that the last time I presented at one of these things, I was presenting before Andy Mitra, and I very rudely said, because Andy was talking about diarrhea, here's Andy Mitra talking shite again. But he's obviously been far too polite not to replay the compliment, because I'm doing gastroenterology and he easily could have done that back to me. Anyway, let me just get mine fired up if I can. We could have an amusing rake through Dr. Finlay's desktop, but that would be rather rude. Is that logging off?
Is that all weighty cases?
So, I was super nervous about this evening because I have absolutely no idea where to pitch this. So what I've tried to do is I've just given you a slightly stream of consciousness series of common issues in paediatric gastroenterology. I've tried to pick out what I think might be some key learning points. You're very welcome to just ignore them completely and take from it whatever you like. If I've pitched it too high or too low, please feel free to just interrupt me as I go along, but don't ask me anything terribly difficult because I've pitched it towards the upper end of my envelope because I'm a very simple doctor. Anybody know any good jokes? Always good to have an emergency joke as a paediatrician. What's brown and sticky? A stick? Come on. Right, please nobody look at how full my inbox is. A lot of them have been paid attention to, they just haven't been deleted, I promise. Right, okay, so, right, common gastrointestinal problems in children. So how did I end up here talking to you about GI stuff? So a long time ago, before I had any grey hairs and needed reading glasses, I used to want to be a neonatologist. because neonatology involved doing really cool things with really sick babies and flying around in helicopters, and it was flat out awesome. Unfortunately, I realised that most neonatologists are grumpy by the time they get to my age. In addition to which, by around about the time that photograph was taken, I was becoming really quite unwell with Crohn's disease, which might have steered my path towards having an interest in GI stuff. Anybody who's ever been in the back of the Sea King will know that there are no toilets there, so having Crohn's disease and being a neonatologist wasn't going to fly. So I decided I would become a general paediatrician because I like doing a little bit of everything, and I guess in a different life I might have been a GP, but I chose to do paediatrics, and I chose to come here because I get to spend quite a lot of time riding around on my mountain bike when I'm not at work, and I much prefer being on my mountain bike. But it doesn't pay terribly well, so I still come to work. Right, so paediatric gastroenterology, hepatology, and nutrition. Everybody loves an acronym, especially gastroenterologists. So all of the gastroenterologists have something PAGAN, British Society of Paediatric Gastroenterology, Hepatology, and Nutrition, European Society, North American Society, Scottish Society. It's also broken down into our regional network of care. So we've got the West of Scotland, WASP PAGAN. We decided we needed one in Dumfries, which we called DumpGAN, which doesn't work quite so well as an acronym, but we thought it was funny. Anyway, so we work as a team. We've got a very strong multidisciplinary approach. Our local GI clinic involves me, a dietitian, a specialist nurse, a psychologist. We try really hard to work together as an integrated team. So we do our specialist clinic, most of us all in the same room together. There's a lot of sort of flex around what that particular child needs at that particular time. So if their issues are more about psychology stuff, well, we might focus on that rather than me doing some fancy medical stuff. We also run an outreach clinic which we link into our local West of Scotland MCN clinic with a team coming down from Glasgow. So they come down every 3 or 4 months. The general ethos of the service is that we wish to provide all of the specialist stuff as close to home as possible. So if you need something which we can deliver here for you in Dumfries, we will do so, even if it's relatively specialist, even if it involves seeing one of the ologists from Glasgow. If you can see them here, so much the better. Or if you need some fancy infusion of something very expensive, if we can do it here in Dumfries, we will do so. On the other hand, if you need something where you genuinely have to go to the Children's Hospital, perhaps an endoscopy, then we will send you up there. So that's the sort of basic model of our specialist service, just to give you a little bit of flavour. So I'm going to take you through some of the things that I see commonly. This is just off the top of my head, but I hope it covers roughly the right things. We'll talk a bit about constipation, because it's all I see in clinic. We'll talk a little bit about abdominal pain, a little bit about celiac disease, a bit about inflammatory bowel disease, and if there's time and if there's anybody left in the audience, we might talk about reflux and we might talk a little bit about food allergy. All right? So, constipation. I picked out some key learning points. It's very common. Some days it feels like it is the only thing I see in clinic. It's usually functional, so there's usually not some big pathological thing sitting there causing it. And really, in fact, if you take nothing else from what I say for the next 15 minutes, just don't be afraid to treat constipation with laxatives. All right? Just keep treating them with laxatives. Give them lots for a long time. In fact, I might even just leave now, because that's actually... Alright, so let's talk about functional constipation. So by definition, there is no underlying pathology. How does it happen? Well, diet is a big part of it. So in the Western world, we eat processed foods that, don't have very many vegetables, don't have a lot of fibre in them. So, the constipation that we see every day just doesn't exist in large parts of the world because of diet and lifestyle. We know that this funny kind of negative feedback thing happens. So in very simplistic terms, something negative happens to the child who's doing a poo. Maybe it's a bit sore, maybe they don't like the toilet, something vaguely negative happens. It's very rarely one discrete incident, it's often just builds up over a long period of time, no pun intended. But the child realises that going to the toilet is vaguely unpleasant, so they decide they're not going to do it again. As you know, toddlers can be extremely headstrong, or at least mine always were whenever my kids were little. When they decide they're not going to go for a poo, they are not going to go for a poo. So then the next time they go for a poo, it's a little bit more unpleasant than it was the last time, and that reinforces their understanding that they were wrong to go for a poo in the first place. So you end up in this horrible situation of really profound toilet avoiding behaviour. Okay, and you'll see these kids who are just desperate not to go to the toilet. That leads them to become very impacted. They get an acquired megacolon. There's the poo. I talk about poo all day long. Apologies to anybody that's not had their dinner yet. All right, so this big, massive poo is sitting in the lower part of their colon, sigmoid, and begins to press down into their sphincter muscles, which begin to dilate. They stop working, and you get overflow incontinence. You get these kids who are constantly soiling, who never use the toilet, who are just in a total mess. They've taken a long time to get to there, and if we had the opportunity to dive in earlier with laxatives to try and break some of that vicious cycle, that would be a good thing to do. Very occasionally, we will come across constipation where there is some pathological cause. We always talk about Hirschsprung's. Every so often as paediatricians, we think about doing a biopsy to look for short segment Hirschsprung's. I have never seen it. All of the kids that I've seen with Hirschsprung's have presented with a profound severe bowel obstruction in the neonatal period. So I don't think that Hirschsprung's belongs on this list. That's personal opinion. I don't think I can prove it with evidence. We also think about one or two other pathological things. Hypothyroidism, you would hope to pick up on that from some other clinical signs. Celiac disease, that one can occasionally trip you up. Obviously celiac, we would typically expect them to present with diarrhea, but they can present with constipation, so sometimes think about that. Lead poisoning, super rare. Calcium disorders, so some of the kids with things like Williams syndrome who've got funny calcium levels and stuff will sometimes have constipation. So we have a bit of a focused think about, is there some pathology causing their constipation, but we recognise, because we don't want to miss it if there is, but we recognise the fact that there's probably not. Treatment. Okay, so if there's a specific thing, find it, treat it, sort it out, but that's usually not necessary. We definitely want to have a big conversation about diet and fluid intake. Changing children's diets is really difficult. By the time we're having a conversation with them about their diet, they're deeply entrenched in that diet. Okay, making children eat peas or something else that they don't like is just very, very difficult, but it's very, very important. So when I was a trainee, one of the guys who taught me a bit about gastroenterology said, there's 23 things you need to know about constipation. Movicol, Movicol, Movicol. And there's a lot of truth in that. Okay, so Movicol is by far our favourite laxative. It works really effectively. It doesn't really have any side effects that we're aware of. Some children don't particularly like the taste. You can disguise it with anything you like. As long as it ends up inside the child, it will be fine. In that child who I described who's impacted with overflow, we require to shift that impaction first. We will use a clear out regime in the first instance. So very rough principles of that might be 2 sachets on day 1, 4 sachets on day 2, 6 sachets on day 3, 8 sachets the next day, and keep going with 8 sachets until they've done an enormous amount of poo down to the level of being sort of just liquid. Okay. Once we've got them cleared out, we would then establish them on some sort of background laxative, typically Movicol. There is no textbook dose. It's whatever dose they require to make them go for at least 1 poo, which is kind of soft, passed without difficulty each day, no blood. Okay, so we would fiddle the dose up or down to get to that steady state, and then we would leave them on that, usually for a long time. Usually certainly by the time they've got to my clinic, you guys obviously would often be seeing them rather ahead of that, but by the time they get to my clinic, they've been constipated for ages. They are used to being constipated, their bowel is used to being constipated, and it takes their bowel a long time to get used to being not constipated. So we leave them on background Movicol for yonks, and then we slowly take it away, because if you just stop it, it just comes straight back. When we take it away, we know, actually once you've got them off Movicol, there's still a moderately high chance of it coming back if something else changes in their life, like they go to school, or they go on holiday, or their diet somehow changes. They might quickly flick back into that toilet avoiding behaviour and end up back in trouble. So I would always advise parents to keep some Movicol in the cupboard after they've stopped it, and to have a really low threshold for reinstigating it. And actually you might get away with just using it for a few days or a week or 2 at that point, because you've jumped on it more quickly. Irrigation pumps. Okay, so health warning. This next bit is purely personal opinion. I have no scientific evidence that says this is the way forward, but I wonder if it might be. You can now get these so actually I'll go back a step. One of the things that we used to do for really profound constipation is something called an ACE procedure, where you get hold of the appendix, bring it out to the anterior abdominal wall. That gave you a stoma that you could put a catheter through, fill up their bowel with a large amount of either liquid or laxative, and they would then have a predictable bowel movement a few minutes after that, so you could therefore make them poo in the toilet. That was quite useful, but it's a really invasive, horrible thing to do, and always has poo leaking out of it, and a bit of a nightmare. So I really don't like these procedures. You can do something very similar, much less invasively. So you can get an irrigation pump. The one that we use is made by Braun. It's called an Irri pump. It's got this little sort of conical foam plastic thing which goes where the sun doesn't shine, and you use that to put in half a litre or a litre of water, which fills up the colon with liquid, and they then move their bowels a minute or two after that, so you have a predictable clear out of their bowel. Okay. My limited experience of this, based on 3 or 4 cases only, of just horrendous constipation where we could not make a single bit of progress. On all 4 of those cases it is now, they have got better like that. Soiling's gone away, they've been doing a stooling into the toilet. It is really quite impressive. So just so if any of you get letters off me, it's something that I am doing a little bit more often. I do not know if it is absolutely the way forward, but I wonder if it might be. That is, like I say, local personal practice. It's not something that's an established, recognised treatment. I mean, it's not completely off the wall. That's what the pump's designed for, but it is something that we're doing a little bit more locally with really quite encouraging results, actually.
Would you continue that long term, or how would you aim to get them back?
Don't know. The 2 or 3 that we've, the 3 or 4 that we've done, a couple of them have remained on it for ages. A couple of them come off it after maybe 6 months or so. I mean, if you can re-establish regular toileting, then happy days. Right, so that's just a reiteration of my learning points. Treat with laxatives, lots, for a while. Chronic abdominal pain, so not quite as big a heart sink as constipation, but nearly. So I see lots of chronic abdominal pain. It's very common, it's usually functional. Right, 1 in 10 rule. Again, personal paediatric practice. Somebody taught me this a long time ago. I don't know if there's a bit of science that says it's true, but it's not far off. About 1 in 10 children will experience chronic abdominal pain. Of those, about 1 in 10 of them have something wrong. Alright, so dead common. Those who have it, relatively rare, they've got something nasty causing it, is the take-home message from that. Investigations are usually unhelpful, but not always. We're going to talk about that in a second. But you definitely need to investigate if there's some warning signs present. So I'll have a think about what those might be. So, very common, this is functional abdominal pain. It's fairly non-specific. There will be an absence of warning signs, which I'll talk about in a second. What's the cause of chronic abdominal pain? We don't really know. I don't know. I don't think anybody else does. It's probably got something to do with a dysregulation of the neurology between the gut and the brain. The gut and the brain have a huge amount of nerves that talk to each other, which I don't really understand, but they're super important and stuff goes wrong with them. So probably what happens in a lot of people with abdominal pain is that something is happening within their gut, and for their brain to perceive it as pain, it should be loud enough to get through a gate, if that makes sense. And perhaps in chronic abdominal pain, those gates are just set at slightly the wrong level. So people have got stuff going on in their gut which might not ordinarily be perceived as discomfort, but in that patient it is, because it gets through to their brain. Right? That's the simplistic way I like to think about it. There's quite a lot of evidence that says that's got a lot to do with irritable bowel. We also know, just as a slight digression, so the kids that we see with neurodisability are really prone to gastrointestinal motility disorders, pain, and all sorts of things. And that is probably again to do with this disruption of the nervous communication between the brain and the gut. Okay, so how are we going to treat it? Well, often the most important thing is reassurance. So these parents, or the children themselves, come along to clinic dead worried because they've got pain in their abdomen and there must be something bad causing that. So sometimes my most important job is to reassure them that there is nothing bad causing it. Okay, that can be helpful in itself. There's a pretty limited role for medication. There's often some psychosocial stuff to do in terms of not finding the bad thing that's happening in their life that's giving them the tummy pain, because that we just never get to that. So we, as paediatricians, when we're not doing our job very well and we don't find anything wrong with a patient, we'll send them off to the psychologist to go and sort them out because it must be all in their head. That model just doesn't work. It's useless. It's a complete waste of time. But what we can do is we can do lots of psychology work, which we might choose to kick off ourselves as the medic involved, which is just about not so much getting rid of the pain, but actually getting on with life despite the pain. All right, and you guys probably know a lot more about this than I do actually, but you can apply that model to all sorts of functional things, and it can be really, really useful. It's a really good way to deal with chronic abdominal pain if you can get the family to buy into it, which is not always possible. That's one of the key ways that we will use our psychologist within the clinic. So if we can do that as a team together, it makes it look much less like I've said, as a doctor, I can't fix you, we're off to see the psychologist because you're mad. And as soon as the patient thinks that, we're clearly stuffed. So we try really hard not to go down that road. Right, some warning signs. There are some patients with abdominal pain who I would be particularly worried about. So non-intentional weight loss, outside of the anorexics where they've got intentional weight loss that's worrying, or growth failure. So we love plotting growth in paediatrics. It's a really important skill, and it will pick up a lot of kids who've got something bad happening to them, like a pathology or neglect or all sorts of other things. Gastrointestinal blood loss, either hematemesis or blood in the stool. Chronic vomiting diarrhea, that can make me pretty twitchy if they've got pain. Fever. Family history. Okay, so if they've got family history of inflammatory bowel disease, celiac disease, maybe a couple of other things, that's going to make their family worried that maybe that's what's causing their pain, but it's also going to make me worry about it because we know that these things have a genetic predisposition. So we're going to focus our investigations a bit more carefully. Or if we find something abnormal on a clinical exam, if they've got tenderness, if they've got a mass, if they've got something wrong in their mouth, like ulceration that might make us think about inflammatory bowel disease, if they've got perianal abnormalities like skin tags, fissures, whatever, if they've got extra-intestinal manifestations, so skin, if they've got something that looks a bit like dermatitis or peptiformis and they've got tummy pain, I might well want to think about testing for celiac disease. If they've got joints and things, with joint pain, etc., because we get joint problems with inflammatory bowel disease, celiac, and some other things. Investigation, really difficult one. We're often torn between whether it's better to do some investigations or not. In the child where you are pretty sure that this is functional, you might be better to do no tests. The danger of doing some tests is that they'll come back normal and the family will then be thinking, well, hang on, we just haven't done the test that's going to find the thing you've missed. And you can end up on this hamster wheel of just doing more and more tests. My personal approach to that, if I'm doing this for pain, I'll often say, look, these are the set of tests that we're going to do. This is going to rule out all of the things that I could be worried about, and actually, you know what, we're not doing any more tests after that because there are no more tests to do. So you can kind of set that up right at the beginning. And if you fail to do that, you can just end up really, really stuck. I'm going to try and focus my investigations based on the history and exam. So, if I've got stuff that makes me think about an inflammatory pathology, I'm going to do some inflammatory markers. I might well do a full blood count and some iron studies. Actually, you know what? Lots of kids have got iron deficiency anemia anyway, just because our diets are so rubbish in this country. But there are a number of diseases which are going to give them some iron deficiency anemia also. I might well choose to do their celiac serology. I have an increasingly low threshold for doing celiac serology in kids with abdominal pain because actually we just find quite a lot of them that are presenting with just abdominal pain. So there's a bit of a tension about that. Calprotectin. So calprotectin, which I think you guys aren't allowed to request anymore, which I'm not sure that's a good decision. I find calprotectin is a really useful screening test. So if you are thinking about doing a calprotectin and you want to write down that I said so, just give me a quick call and I'll say, yes, please do a calprotectin. So it's really sensitive, not particularly specific. So if you've got inflammatory bowel disease, your calprotectin will probably be up if your inflammatory bowel disease is active. And if you've got a normal calprotectin and you've not been treated with anything, your chances of inflammatory bowel disease are diminishingly small. So we use it as a screening test. We're also beginning to use it quite a lot as a sort of monitoring test. So for patients who we know have inflammatory bowel disease, we're sometimes using it to mark how active their disease is or whether they're having a flare. Those with abdominal pain who I do a calprotectin which comes back elevated would then be a trigger to do a whole bunch more IBD investigations. Again, a reiteration of some learning points which I think are possibly very simple, but that's my approach to abdominal pain. Celiac disease. Alright, so this might get a bit more sciencey. Apologies if it does. Key learning points. I'll talk a little bit about what celiac disease is. going to emphasise the importance of staying on gluten until we know what's going on. And I'm going to talk to you about some new-ish, they're a couple of years old now, guidelines within paediatrics, which sometimes allow us to make a diagnosis without biopsy, which is a really cool thing to do. I don't think the same guidance applies to adults. I have no idea why that is, because it should be. But anyway, we'll talk about that in a moment. So, quick definition of celiac disease. So it's an immune-mediated systemic disorder elicited by gluten and related prolamines in genetically susceptible individuals characterized by the presence of variable combinations of gluten-dependent clinical manifestations, CD-specific antibodies, and particular genetics, HLA, DQ2, DQ8, and an enteropathy. Okay, so you have to have some gluten, you've got to have some genetics that sits behind it. It gives you some tummy upset, okay, and it's absolutely related to gluten. Now it's different to a gluten allergy, which would be mediated by IgE, IgG, so it's a different immune mechanism to allergy, okay. Common presenting features, you know this: diarrhea, pain, irritability, fatigue, weight loss, failure to thrive. It can be very, very variable and very, very vague. Traditional paediatric textbooks will show you this picture of this scrawny scrap of a toddler with wasted buttocks and ribs sticking out everywhere. We just don't see that anymore, okay? It presents in a much more subtle way these days. You might pick up on it because of non-intestinal things like dermatitis herpetiformis and some other stuff. We know to watch out for celiac particularly carefully in some at-risk groups, those with autoimmune disease such as thyroid disease, diabetes, and we go screening for it in particular in those, also in Downs, and also in IgA deficiency, which is a real pain because our favourite screening test is IgA dependent, so our TTGs don't work in patients who are IgA deficient. Helpfully, the laboratory tell me that when I send them a sample for TTG, they will also just check the IgA and they will get back to me if the IgA is low, so that I know that the TTG is not particularly useful in that patient. Right, celiac iceberg. You might have seen this before. There's tip of the iceberg is people who've got barn door celiac disease. They've got very obvious disease. They've got mucosa lesions where if you biopsy them, you can see obvious, sort of villous atrophy and lymphocytic infiltration into the mucosa. Sitting below that, you've got what we would call silent celiac disease. Okay, so these are patients who aren't particularly symptomatic, but if you happened to do their blood tests and some biopsies, you would notice that they had celiac disease. Okay, actually, that group of patients, if you happen to pick up on it and you treat them, they then go, oh gosh, I feel well. And actually, they probably did have some symptoms, but they just weren't really picking up on it because that was the normal that they were used to. And then we have this thing, latent celiac disease, which is those people who have a genetic susceptibility to it, and some positive serology, but they don't have any mucosal lesion. Okay, so they might well go on to get celiac disease, but they're not there yet. Yeah, that's a bit sciencey. Right, okay, so this is about our diagnostic pathway. Don't get too worried about the content of the slide. The key thing to take away from this is that the current guidance, new guidance from the European Society of Paediatric Gastroenterology, Hepatology and Nutrition, if we've got children who've got what looks like celiac disease, and they've got a really high TTG, which means more than 10 times normal, and they've got an HLA genotype that's consistent with celiac disease, so that means either HLA DQ2 or DQ8, we can diagnose them as having celiac disease, as long as they get better when we take gluten out of their diet. Yeah? So, looks like celiac disease, has all of the lab tests that fit with celiac disease, get better on a gluten-free diet, you've got celiac disease, which is great, because we don't like doing biopsies to kids if we can get away with it. On the other hand, if their TTG is a bit iffy, up a bit but not up enough, if their symptoms are a bit more subtle or equivocal, we still need to biopsy those kids. Okay? Difficulty with all of this is that it all falls down if they've gone on a gluten-free diet. So we will often have patients who pitch up to you or me or somebody else where we're starting to think about celiac disease and the parents take them off gluten and they get completely better. But we've not done this stuff first, so I can't give them a diagnosis. Right? You could argue, and many parents will, well, my child's better anyway, so actually I'm happy. Cheerio, see you. Difficulty is that they will have celiac disease forever unless we come up with some new way of treating it which doesn't exist yet. Okay, so their celiac disease puts their skeleton at risk, particularly if they're female. It puts them at risk of things like gastrointestinal lymphomas if they are non-compliant with their diet. And we know that whilst you might have a little 5-year-old whose mum is in complete control of his diet, and he's totally gluten-free and that's fine, but he's going to turn into a really horrible 15, 16, 17-year-old who's going to go out and drink beer and eat pizza because he likes it, because it's nice. But actually, if he's got a nailed-on diagnosis of celiac disease right from the beginning, it's much easier to tell him the importance of sticking with that diet. He'll still go out and drink some beer and eat some pizza because that's what teenagers do. But it does make a difference to that compliance with stuff over a long period of time. So getting the diagnosis nailed at the beginning is really important, and you can only do that if they're still on gluten. Otherwise, it all just gets really, really awkward. Right, just to reiterate learning points. A little bit about IBD. I've already mentioned some of this as I've been twittering on. Predominantly Crohn's disease, ulcerative colitis. For reasons that are not entirely clear, if you come to the paediatric GI clinic in Dumfries, you've pretty much only got Crohn's disease. We actually haven't got anybody on the books with UC at the minute at all. And we haven't had for ages. And that doesn't make sense, and it's not statistically correct, but that's just the way it is. I think it's just a statistical fluke rather than anything else. We also have 1 or 2 kids who will have this indeterminate inflammatory bowel disease with a little bit of features of both, and it's difficult to make a definitive diagnosis one way or the other. Incidence is going up quite rapidly. Really interestingly, the incidence of paediatric inflammatory bowel disease, if you look at it anywhere in the world, it goes up in tandem with social economic development, and it tracks diabetes. So if you put on a big growth chart a country's GDP over a long period of time, and then you map the incidence of diabetes type 1 and also inflammatory bowel disease, they all go up in tandem. So there's some really strange social, environmental thing that happens. So we also know there's genetics that sit behind this. So presumably what happens is that some people are genetically predisposed to inflammatory bowel disease, like me, which is a bit of a pain, and then something comes along to switch on their inflammatory bowel disease. Okay, we don't really know what that is. It might be bacteria, it might be something else. Okay, but it has something to do with social economics. We also know that peak onset is in adolescence and early adulthood, so lots of them will come to paediatric clinic. Current treatment. Okay, so there's probably a little bit of difference here between paediatric and adult practice. So first thing we need to do once we, this is more about Crohn's disease than UC. You can apply a similar sort of model to UC. There's some subtle differences, but I focused more on Crohn's because it's what we see mostly. So first thing to do is to get them better. So we do something to induce remission. Traditionally that would have been steroids, which work really well, but have lots of horrible side effects. We now use modulin, okay, so this special liquid nutrition which they take as exclusive nutrition, nothing else apart from Sprite and Fox's Glycine Mints, okay, because they have to have something with a little bit of taste to them. They get that for 8 weeks. That switches off the immunological load within their gut calms down, and it's pretty much as effective as steroids at inducing remission, but without any of the side effects, okay. Really cool, medically safe, no side effects, brilliant, tastes bogging. On that for 8 weeks is not straightforward, so about half of our kids need to get it by a nasogastric tube, about half of them manage to take it voluntarily. Once we've got them better, we put them onto some maintenance therapy, bit of a step-ladder approach, very simplistically. Azathioprine is probably at the bottom of that ladder, followed by methotrexate, either subcut or orally, followed by the monoclonals, infliximab being the first line, adalimumab thereafter, and then there are some newer biologics like ustekinumab and some other imabs that I can't remember the names of. Okay. Within Dumfries, we've got a couple of patients on adalimumab, 3 or 4 on infliximab, a couple of methotrexate, and half a dozen or so on azathioprine, just to give you a rough spread. But we think about it very much as that kind of step-ladder sort of approach. And if you are doing well on azathioprine for a couple of years and then you flare up, we'll reintroduce remission and maybe put you onto methotrexate, sort of move you up the ladder. Difficulty, of course, is as you get higher up the ladder, you start to worry about where you might go next. You just keep hoping they keep inventing new drugs. So, cause of IBD, not really sure. We know there's genetics involved, we know there's some environmental stuff. We know it's to do with activation, deactivation of gut inflammation. So one of the relatively sexy genes that's involved in IBD is this thing called NOD2, which you may or may not have heard of. NOD2 is involved with the switching off of inflammation. So your gut's really, really immunologically active. It's just about the most immunologically active bit of your body. Stuff comes in, your gut reacts to it, it's supposed to, it keeps you alive. But then once it's dealt with that threat, it's supposed to switch back off. Very, very, very simplistically, maybe something switches on, but it doesn't switch off the inflammation and you carry on being inflamed. Right? So NOD2 is involved in the switching off of inflammation. We know if you've got NOD2, you're more likely to get IBD. There's a whole bunch of other genes which are implicated as well. It is a multi-gene disorder. Okay, so hot topics include genomics. Right, genomics was very, very sexy about 5 years ago, where we were looking at the whole genome and trying to pick out various different genes which predispose you to various different types and phenotypes of inflammatory bowel disease. That's become less sexy, not quite sure why. Current sexy thing is the microbiome, so the entire microbiological flora of your gut, and we know that patients with inflammatory bowel disease have a rather different microbiology makeup to those who don't have inflammatory bowel disease, and maybe, if you can influence that, you might be able to prevent, treat, change inflammatory bowel disease. All right, there's a whole bunch of maybe in that, but it might be in the future. Or maybe something else will be sexy in the next 5 years, we don't really know. Right, have I run out of time yet, or am I still okay? Keep going for another couple of minutes. Right, so gastroesophageal reflux. So my bugbear around this is to be very careful about working out whether children have reflux regurgitation or are vomiting. They are different. Reflux involves the effortless regurgitation of stomach content. Vomiting involves activation of the vomiting cycle. Okay? Those of you who ever so occasionally drank too much alcohol at medical school will be familiar with the vomiting cycle, where you go a bit pale, you feel a bit sweaty, you start to have some stuff going on in your tummy with these forceful abdominal contractions. I'm sure I wasn't the only person to experience that at medical school. Please tell me that. Okay, so that is caused by various noxious triggers in either your gut or your brain, picking up on stuff and triggering off that cycle. Okay, reflux is different. That just doesn't happen in reflux. They simply have the effortless regurgitation stuff. Okay, so babies, small children, all of them reflux a bit. Some of them reflux a lot. Some of them reflux so much that it becomes a disease. So that's the difference between gastroesophageal reflux disease. The ones I get interested in are the ones who've got disease, which means they've got so much acid coming up, they've got esophagitis and pain, or they've got respiratory compromise, or they've got failure to thrive. Those ones I'm interested in. Okay. If I see a small child who I think has vomiting, I'm going down a different pathway. Do they have a urinary tract infection? Have they got a brain tumour? Is something else horrible going on? Okay, so small children who keep having genuine vomiting outside of a gastroenteritis or something, I'm a little bit more worried about. Treatment, okay, so we've got very few useful treatments for reflux, which is a real pain. We used to use lots of prokinetics like cisapride, domperidone, but we get really worried about their QT intervals and the risk of sudden cardiac death, which is not really an acceptable side effect for something as trivial as reflux. So we can suppress their acid with ranitidine or omeprazole, which we do a lot. The most important treatment in most cases, time. It will get better as they grow and stretch and become more vertical and the lower esophageal sphincter matures. Okay, so time is absolutely critical, and often our most important job is just to reassure them that they will be okay in the end. I've not even put anything down on the food allergy slide because I wasn't sure whether I would have time and I wasn't sure how much you want to talk about it. Highlights of food allergy. We do seem to see rather more cow's milk allergy than we used to. Not entirely clear why. Maybe we're just better at diagnosing it. Maybe something's changed. Major issue around cow's milk allergy. It's got nothing to do with lactose. Apologies to those of you that already know that. Lactose, sugar. The intolerance of lactose is to do with the fermentation of the lactose as it gets into the bowel, which gives them bloating, pain, diarrhea. It's pretty rare, so it's caused by a congenital absence of lactase, which is a rare condition. It happens commonly as a transient thing when you get a gastroenteritis and wipe out the tips of your villi. You can't absorb your lactose and get a transient lactose intolerance. Cow's milk allergy, completely different. Allergy to the protein, presents with often reflux, often diarrhea, tummy pain, respiratory symptoms, rash. Okay, gets better with taking the cow's milk away from the diet, which is really the only useful test that we have for it. I'm going to stop talking at that point because I'm not quite sure how much time I've taken up. Apologies if that was a bit fast. I'm aware I've been talking far too quickly. Hopefully some of it was vaguely useful. Any questions?
If you see a child who, and then your parents would say that we think he's sort of gone on to a gluten-free diet and they're much, much better, and you are keen to test them, How long do we need to go back on looking for before you would undertake any testing?
So, the proper answer to that question is I go and ask the dietitians because they've got a proper pro forma, and not only will it tell you for how long, but it can give the patient, family, specific advice about portion sizes and how many portions of gluten-containing foods to take. So if I'm stuck in that kind of thing and I want to test and I want to get it done properly and out of the way, I'll actually often get the dietitians to make contact with them because they do it much better than I do. But 2 or 3 portions of gluten a day, so a slice of bread, a portion of pasta, usually for sort of 4 to 6 weeks, that kind of time period. But when I want to do it properly, I ask the dietitians because they do it in a much more structured way than that. And then you know that you're doing it properly, as opposed to just taking a bit of gluten and see how you get on. Stunned silence means that was either really good, really bad, or you're all just really fed up and want to go home.
In babies with reflux, do you dislike us using Gaviscon? Sometimes I get mixed messages. Some people say just avoid Gaviscon because it constipates and jumps straight to ranitidine or omeprazole, or do you still think it should be a first line?
I prescribe very little of it because I don't find it to be desperately helpful, and I do see it causing things like constipation. I don't have a particular objection to it being used. If you use it and it is found to be helpful and it doesn't cause a problem, that's great. But personally, I don't prescribe very much of it.
But equally, you're quite happy for us that she's involved.
I've got no problem with it. I mean, it's important to remember that we are seeing different groups of patients. The ones I'm seeing will have been seen and dealt with by you guys already. So at a much lower level, I have no problem with using Gaviscon. I just don't personally prescribe it terribly much.
The only other thing is constipation glycerol suppository.
I don't use them often. We use them quite a bit in neonates and very small infants, but they are more likely to have something else wrong with their gut and some form of.
Would you kind of recommend that in general practice?
I would generally avoid them. In general, you are better off to use laxatives from the top end in whatever dose is required to get them moving again. The potential disadvantage of using suppositories would be it becomes an unpleasant experience for the child or young person, and then run the risk of amplifying that toilet avoiding behaviour stuff.
You said.
Sorry?
You said time is a factor in gastroesophageal reflux.
Yep.
So what stage do you start prescribing, say, radical?
So I would normally start prescribing them some stuff when I'm worried about them. So if I think they meet the criteria for having some reflux disease, I'll put them on either ranitidine or omeprazole. And how long I leave them on is very variable. It depends on the circumstances. Most children will grow out of their reflux by around about a year, by the time they're spending a lot more time vertical and they've stretched and their esophageal sphincter is usually matured by then. There's definitely a subset of kids, however, whose reflux lasts rather longer than that. But even those children, it will almost always get better. A tiny number will have such severe, such profound reflux that we might eventually go on to doing something like a fundoplication where we'll get part of their stomach and wrap it around the lower part of their esophagus and nip it tight to stop the reflux. But that's a very dramatic thing to do, and we're only going to go there when you have troublesome reflux for a long period of time that hasn't responded to medical treatment.
Is there any benefit in changing to milk reflux? So it's been come in and see on
Yeah, so the anti-reflux milks, I think my comment would be similar to the Gaviscon comment. I have no objection to it being tried. I'm not in the patients that I see, it's not particularly helpful, but maybe for other kids it might be. What I often find to be unhelpful, which is incredibly easy to do, and I've done it myself by accident lots, is just constantly chopping and changing the milk. So if milk is part of the problem, and we're often then talking about allergy, you kind of need to be on your new milk for 3 or 4 weeks before you will get better. So the milk allergies that we see, they're very slow burning allergies. They have a slow onset and a slow disappearance. So, if you put somebody onto a low allergy milk, you want to be on that for at least 4 weeks before you are convinced that it's not going to work. And it's often, parents are often at their wit's end, and so that, they'll come back 2 days later, it's not any better, doctor, I want a new milk. And you give them a different milk, and then, well, that one didn't work, so another milk, you just haven't found the right milk yet. And so I try really hard to avoid that. I sometimes fail, like everybody else. But that constant chopping and changing milk is often unhelpful. It's just got thickening stuff in it, various different things. I mean, you can add thickener as well, which has the same effect. I generally don't find them to be desperately helpful. Okay, should we draw things to a close at that point?